It is a pleasure to be here, and thank you, Mauricio, for including me and this topic in the agenda. And thank you again for being here and awake after lunch. So I want to talk very briefly about the burden of stroke and talk a little bit about some of the stroke disparities that we have recognized. Tell you about a project called the Florida-Puerto Rico Collaboration to Reduce Stroke Disparities, of which Sarasota Memorial Hospital is participating and providing very important data. I'll show you some of the early data that we have and talk to you a little bit about next steps. So I'm sure you've seen this during the day. Stroke is the 5th cause of death in the US, 3rd cause of adult death worldwide, and it affects minorities disproportionately. And that is true here in the US, and it is true around the world, in that those that are economically disadvantaged have worse outcomes. We are a very varied society here in the US, and this is the distribution by race ethnicity, both in 2012 and a projection for 2060. And as you can see, we will become much more diverse in the near future with a great growth in the Hispanic population in this country. Now, what are disparities? Well, health disparity is the unequal distribution of diseases across a population. And here in the US, we have traditionally described disparities across race-ethnic lines, but there are also disparities by gender, geographic disparities, and you all know about the stroke belt. But even more locally, there are disparities, geographic disparities within states and counties. And there are multiple factors which are complex and interact between themselves to account for these disparities. But what we now know from many, many studies in many disease states is that genetic factors play a very small role in these disparities, very small role. And it is really access and utilization of healthcare and insurance that probably plays the largest role of all in disparities. So just to give you a little sampling of the disparities that we're talking about in our area of stroke, there is a significant disparity in the access to thrombolysis. And just to give you an example, delay in the emergency department as a reason for TPA eligibility, in arrival to the emergency department, 81% in African Americans versus 58% in non-Hispanic whites. But once they get to the emergency department, the waiting time before they're seen by physicians of more than 10 minutes is much greater for African Americans than for non-Hispanic whites and for Hispanics. Now, TPA has increased across all race ethnic groups, as you can see over the years, but there's still a disparity between whites and African Americans. And if you look at the disparity overall in TPA utilization by race, it persists even in those that get into hospital within 3 hours. And even in endovascular therapy, within centers that can provide thrombectomy, that is the more advanced centers, there is a significant disparity in the utilization of endovascular approaches. As I mentioned, there is a strong social, economical portion of these disparities. If you look at mortality for uninsured compared to privately insured patients, there is a significant difference for those that are uninsured. And very importantly, if you go to a hospital that is in a low-income area, even adjusting by socioeconomic characteristics, the risk of mortality is greater, and the risk of the use of thrombolysis has to do, or the chances have to do with your income. So these are areas that are in need of addressing. They are not the way that we want to live in an unfair system. As you know, we're looking at rehospitalization as a marker that the hospital is doing a good job, and we're being dinged if we have high rehospitalization rates. And there are disparities for rehospitalization by race ethnicity, with Hispanics and African Americans having higher rehospitalization rates. Now, Florida is interesting. As you well know, we have a greater proportion of African Americans and of Hispanics than the rest of the country, more minorities. And African Americans and Hispanics are younger than their white counterparts in the state. And that means that in the future, as we grow older, we're going to see a larger number of African Americans and Hispanics that will be at greater risk for stroke and for stroke disparities. Now, while mortality from stroke has been decreasing in Florida for all groups, and we have just started tracking Hispanics formally in the state, there is still significant disparities that persist as they do across the country. Now, as you know, the population density of the state is concentrated along the coasts, but stroke mortality is greater in the northern part of the state, in the Panhandle, and this probably represents a dipping down of the stroke belt. But this is also the area where we have less neurologists and less stroke centers, and also lower incomes. And that gives you an idea of disparities, both geographic and by the access to healthcare. So based on these disparities, the NIH has funded now 4 projects to try to decrease stroke disparities. And these are the sites doing research on stroke disparities funded by this award by the NIH, 2 in California, 1 in New York, and then the project in Florida and Puerto Rico. And the project that we are conducting is a 2-step process. The first is to identify disparities across the state and Puerto Rico, and then to try to implement measures to decrease these disparities. And what we have decided to do is to leverage the very large and well-utilized registry of Get With The Guidelines that many, many hospitals use, and then try to add some data to that registry, analyze the data, and then develop the interventions for decreasing stroke disparities. We're looking not only at the individual factors that are in Get With The Guidelines, but also at system-level factors, hospital-level factors, and then looking at some of the classical outcomes that we are getting from Get With The Guidelines, such as the measures that we report to the Joint Commission, and a few others that the payers will be looking at in the future, and then see the effect of education, evaluation, and feedback to the healthcare facilities on these measures. And we're adding to the Get With The Guidelines, to those of you that know Get With The Guidelines, information about language, education, and medication adherence that are important predictors of outcomes. We currently have 84 hospitals in this registry, 69 in Florida and 15 in Puerto Rico, with many just coming on board. And if you look at those hospitals that could potentially be eligible for this registry because they are acute access care hospitals with an emergency department, then you look at the current Get With The Guidelines hospitals and the ones that are in the registry, you see that we capture about 50% of the Get With The Guidelines hospitals. And as I'll show you in a minute, I think that this sample is very representative. Now, don't look at 2015 because the data is slow to come in, but as you can see, you can rapidly accumulate numbers in the registry, and although we have data from before 2010, we decided to start the analysis with data from 2010 onwards, because that's when this data became stable, the number of hospitals and so on. And these are the demographics that we are looking at, and this is just a very early view, and these data change over time. You see the regions here. We have decided to divide the regions in South, West Central, East Central, North and Panhandle together, and then Puerto Rico with very few numbers just now, but this will increase rapidly. And as you can see, in West Central Florida, there is a greater proportion of non-Hispanic whites compared to the rest of the state, particularly to the South. If you look at the stroke subtypes, you see that overall about 69% within this registry have an ischemic stroke, 12% intracerebral hemorrhages, 5% subarachnoid hemorrhages. TIA is 14%. Interestingly, TIAs are more prevalent in non-Hispanic whites. Whether this is because they have more atherosclerotic disease that presents more with TIAs, or perhaps because these patients have greater stroke awareness and come into hospital more, that's an area to be further explored, but again, an area of disparity and potential intervention. And indeed, in West Central Florida, within the registry, there's a lot more TIAs than in the rest of the state. And interestingly, lower rates of subarachnoid hemorrhage within the registry. If you look at insurance across the registry, overall about 38% have a private insurance, another 34% have Medicare, and again, significant disparities by race ethnicity, as one would anticipate. And what we are looking at in regards to outcomes are the typical outcomes that we report to a Joint Commission based on the registry as stroke hospitals. There's a measure called defect-free care that some of you may be familiar with, and these are the measures that for which a patient is eligible. So if a patient is eligible for TPA, for thromboprophylaxis, and for warfarin and discharge, then if you account for all of those, then you have 100% of your measures and you're defect-free. We're also looking at other things such as TPA overall. Remember that the measure that is reported to Joint Commission currently is TPA by 3 hours for those that arrive within 2 hours. But we're looking now at overall TPA because we are now treating in many centers up to 4.5 hours from onset. And we're also looking at the time to CT. So we wanted to first make sure that our hospitals in the registry were representative of the rest of the state. And these are, again, only Get With The Guidelines hospitals across the country and within Florida. But remember that there are 1,600 hospitals across the country using Get With The Guidelines. And we find out that for all of these measures, we are very similar, except that in the registry, and actually in Florida, we're treating within 60 minutes less than in the rest of the country. Although we're treating within 3 hours at the same rate as the rest of the country. That means that we're not treating in the 3 to 4.5 hours as much as other places are. This is defect-free care by race ethnicity by each year. And what you can see from this graph is that over time, for all race ethnic groups, there has been a significant improvement in defect-free care. That means that if you look at your data, any way that you want to look at it, but that's what the Get With The Guidelines registry provides, you get better. You see where you're not doing well and you improve. So that's great news. Puerto Rico is doing worse, but as I'll show you, they are catching up very rapidly because they have just instituted Get With The Guidelines very recently. So I'm going to show you a little bit of data, not a lot, because in many areas we're doing very well, and I don't want to remark upon those areas, in part because of time also. But I'll show you some interesting data. So this is the use of TPA for within 3 hours for those that arrive within 2 hours. And this is by region. And you can see that overall we're doing very well, and we're improving. So let's look here at West Central Florida. In 2010, and that's not that long ago, we were not doing that well, but we have rapidly improved over time, over a few short years. So that's exciting. Now, this is TPA use within 4.5 hours for those that arrive to hospital within 3.5 hours. And here, we're not doing so well. So this is overall in the past 5 years for West Central Florida. And again, lower rates, significant improvement by 10 percentage points. But still, overall, small numbers are being treated in the extended window of those that are eligible. Let's look at door to CT within 25 minutes. This is arrival to completion of the CT, and this is a guideline that patients should be scanned in the first 25 minutes. And you see here that overall, we're not doing that well. This is a proportion of patients that have their CT within 25 minutes, and less than 50% are completing this guideline or this milestone. So a lot of room for improvement, with some differences by state, by region. This is a median door to needle. And as you know, there's this concept of the golden hour, which if a patient arrives, you want to get everything done and TPA infused in those that are eligible within 60 minutes, because you're losing 1.9 million neurons per minute of ischemia on average. So shorter is better. The new guidelines are trying to push the envelope and suggesting that perhaps 45 minutes is the way to go. And this is where we are across the state. And again, these are medians. That means that 50% of the patients have worse times. So this is the average over the past 5 years. And you can see here that the median is above 60. This is pretty bad. And again, there are some differences over time and by region. Now, this is the proportion. This is another way to look at it. Instead of the median time, this is a proportion that get treated within 60 minutes. And again, less than half of the patients are being treated within 60 minutes, with significant regional differences as well over time. We then wanted to look at whether, once you adjust for multiple variables across the registry, there was a race-ethnic difference. And we decided to differentiate the Puerto Rico Hispanics from the Florida Hispanics in these analyses because of various reasons, including small numbers and different health systems and so on. But once you adjust for multiple covariates, there are a few things that come up. First of all, in Puerto Rico, the odds ratio of early antithrombotic use, antithrombotics at discharge, and the use of statins at discharge, which was much lower than for Florida whites, and this is a comparison group. And in Florida, African Americans have a lower chance of having smoking cessation counseling than Hispanics or whites. And that's an area that can be addressed and should be addressed. As I've shown you, there's been temporal improvements in all of these measures, and in particular for defect-free care in Puerto Rico, significant impact with more than doubling of the defect-free care over time. And this is a power of looking at data and acting on the data that you have. We also looked at the use of TPA by race ethnicity. I told you in the previous slides that there was no difference in the arrive by 2, treat by 3 for African Americans. The only thing that came out was the smoking cessation counseling. But if you look at TPA use within 4.5 hours, again, after multiple associations and corrections from multiple covariates in the multivariable models, there is still a lower utilization of TPA for African Americans than compared with whites in Florida. And again, another disparity in the registry. I've shown you this before, 25% lower chance of smoking cessation in African Americans. Smoking cessation counseling, we don't know about the efficacy of that counseling yet. This is just the counseling itself. We also looked at gender differences and overall improvement in defect-free care overall for men and women. And although the use of TPA within 3 hours was the same for men and women, if you looked at the use of TPA by 4.5 hours, we see a significant difference that was statistically different in women compared to men. And actually, women had longer times to CT and longer times to needle than men. Again, the causes may be complex, but that is another disparity that needs to be explored. So where do we go from here? Well, we're going to be looking at other metrics, not the traditional metrics that we report to get with the guidelines, and we've already started with time to TPA up to 4.5 hours, with time to CT, and we're looking at a few others. As we get more data that has socioeconomic factors and language and education, we're going to be including those in the models, which we haven't yet because we don't have the data. And we really want to look at delayed outcomes, not only at discharge outcomes. Unfortunately, there's very little data in the registries and across the country in general. So we are looking at CMS matched data for those patients that are in CMS, in the CMS database. And we're also going to link with EMS databases across the state for pre-hospital covariates that may influence outcomes. So this is what we're doing with CMS. We're looking at our outcomes, and then we're comparing that to the CMS data for readmission and mortality. And then we're going to compare that to the national databases. We're going to be merging our data with the EMS MSTARS database. And again, not all EMS systems are in MSTARS, but about 75% of them in the state are in this large registry. We're continuing with educational activities and with feedback. And I wanted to show you some of the things that we're doing. And I was just talking to Agnes that we have sent out our first Disparities dashboard, and these will be hospital-specific data, comparing it to the state, and I think that this will be very useful. So what we're doing is looking at first defect-free care, but also some of the other traditional measures, and initially we're doing it by race-ethnicity for Florida. In Puerto Rico, we're comparing them to Florida Hispanics. That's what we decided to do. And this is just a hypothetical hospital that has a ranking of 28 across the Florida registry. That's how they ranked in defect-free care. And again, this is in gray the state performance, that particular hospital's performance for whites, Hispanics, and African Americans. And this is an area where there may be some action at the hospital level, at the institutional level, that would be important to have this feedback. So for example, and this is door to needle within 60 minutes. This particular hospital did very well for their white patients and was below the state average for their Hispanic and African American patients. Again, an area where root cause analysis needs to be done, identify the factors that result in this behavior and correct it. So I hope to have left you with the idea that stroke disparities do exist, that the causes are complex, and we don't know what the root causes are for the most part, and certainly not for each individual disparity. But at the same time, we cannot be laissez-faire about it and say, well, we don't understand it, there's nothing we can do. We need to address this, and by improving stroke care for all, we're going to also improve stroke care for minorities. So I think that this is an important project. Thank you for your participation in the Florida-Puerto Rico collaboration to reduce stroke disparities, and I think that we'll see much more interesting data in the future.